right, good afternoon. I was at the meeting in 1999 at BU. I was one of the young people at the very top. I will say I will not be at this meeting in 25 years from now, so I'm going to try to, if I am, please make sure I leave. So my job, Helen, thank you for giving me an opportunity to talk about this. I'm going to try to summarize where the field is today and try to conceptualize it in a way that we can help our patients and then as well as our society. By way of disclosure, I will keep this up here, John, so everybody can see it. I have no disclosures that are related to this topic. I am a co-founder of a company that is related to bladder cancer, and all of my grants are related to cancer. However, I have been either a PI on a tissue engineering trial, as well as multiple stem cell trials. And out of the 4 trials that revolved around regenerative medicine, 3 of the 4 were for erectile dysfunction. So that is my previous disclosure. So I think this is an important slide to talk about regenerative medicine, and it gets a little muffled up at meetings. This is a new field, 2008. It was the first description. In the description of regenerative medicine is a replacement or regeneration of human tissue, cells, tissue, organ function in order to restore an abnormally functioning organ to a physiologically intact organ. And then restorative therapies, which we often hear, utilizes regenerative medicine technologies to reestablish organ dysfunction. And I'll show you examples of that in sexual medicine. So the goals of regenerative medicine is to use a minimally invasive approach to avoid the need for major surgeries to restore organ function, long-term solutions, i.e. cure, and a personalized approach, so where we can take patients' own autologous cells, potentially engineering them ex vivo in the lab, and then replace in order to restore organ function. This is where the field of regenerative medicine is today. The use of PRP, which we'll discuss in detail, stromal vascular fraction, amniotic fluid, a couple of publications, but I'm not going to speak about those much, and then stem cells. So this is regenerative medicine, whereas restorative therapies is something like low-intensity shockwave therapy. The indications for regenerative medicine approaches, i.e. restorative therapy or shockwave, is erectile dysfunction, Peyronie's disease, and penile enhancement. At least that's what has been published. It is being utilized for other indications, but that's what the literature would show. Briefly, as it relates to low-intensity shockwave therapy, if you look at sort of the effects on the interstitial tissue or the tissue microenvironment, it has been shown in preclinical models to increase progenitor cells, either resonant or from the bone marrow, to help have local proliferation of these progenitor cells that can either secrete growth factors or become a new cell in that organ. So that is the thought. So that's why shockwave is a restorative therapy. So what are the recommendations for restorative therapies today? This is a publication from last year. The AUA, in a position statement and in the guidelines, says as grade C level of evidence for the use of either shockwave or stem cell therapy, and PRP is experimental. The EAU takes a little bit of a different stance, and I'll show it later in the talk, where they actually say there is evidence, weak evidence, but still evidence, for mild to moderate ED, and then there is no role for either stem cells or PRP. It is experimental. And the SMSNA has said in a position statement that there lacks robust data, clinical data to support the use of restorative therapies, such as low-intensity shockwave therapy or stem cells PRP. We'll revisit this a little bit later. So what's happening around the world? Publication from a couple of months ago. This was a questionnaire that was sent out internationally. The majority of the people that responded were from Asia about the use of restorative therapy throughout, regenerative therapy for ED, global practice patterns. This is who answered the questionnaires. The majority of the people answering were from Asia, as well as Italy. You can see here not many respondents from the United States. But what did they find? So the most used modality was low-intensity shockwave therapy, 5% of the respondents, PRP in 25% of the respondents, and less than 5% of stem cell therapy. And then what is the most common cause of not using, why wouldn't you use regenerative therapy for the treatment of male ED? And it's interesting, the results are kind of exactly what you would expect. No experience, it's not covered, it's not available, but more importantly, it's way down, only 12% said it's not recommended by guidelines. So it sort of tells you that even though we give our recommendations and we show the evidence for this, most people are really going to use it despite what the guidelines say. And and then if you could see in the lower panel here on my left, the proportion of patients who showed improvement after regenerative therapy in this practice, and this is once again questionnaire, the definition of exactly what improvement means in this study was not fully defined, but actually only about 25% said that 50% of their patients responded. So even a questionnaire that's asking this question demonstrates that really there's very little lack of efficacy. And I find it appalling, frankly, that people are using this form of therapy for psychogenic ED. We all know that this is probably not indicated, and we need to be approaching this in a very different way. I'm not saying that they wouldn't need some type of vasculogenic therapy in the future, but nonetheless, this is what the data showed. So what about our society, SMSNA? This is an abstract that was presented last year, asking, is it utilized? They call it penile regenerative therapy, trends and evidence. And you can see that only 20% of our members are utilizing shockwave, and only 11% for PRP. Once again, abstract from last year. So I would say a lot less people are utilizing it, either or potentially people using it and not saying. So what is the clinical evidence for PRP and stem cells? I'll start with stem cells because it's pretty straightforward. The most common form of stem cell-based therapy for ED, male ED, is mesenchymal stem cells, in particularly adipose-derived stem cells. Additionally, stromal vascular fraction, which is isolated via a machine. None of these machines are FDA approved currently. So you can get the stromal vascular fraction, which includes stem cells as well as multiple growth factors. These are the trials that have looked at stromal vascular fraction, stem cell-based therapies, mesenchymal stem cells, amniotic fluid, and the like. I purposely, please understand, I don't expect you to see any of this. I just want you to know that these are all phase 1 or phase 1A, 2A trials, which have shown safety but no efficacy. My understanding is that there is going to be a phase 2 trial that will be published soon in European Urology looking at this in post-radical prostatectomy. That my understanding is it may be positive, but nonetheless, this is not really where our society or internationally it's being utilized. Well, what about PRP? PRP is platelet-rich plasma. It's isolated. You then activate it in order to release growth factors. And then the result is thought to be release of growth factors which promote angiogenesis, neuroprotection, and it changes the immune microenvironment to promote wound healing. Platelet-rich plasma falls under the HTP 361 exemption because it's autologous, so you don't need FDA approval, and therefore it's being utilized broadly. These are the 4 trials that have looked at it in patients with mild to moderate ED. I will point your attention here. These are the 3 trials that I think I'll discuss briefly. They're giving 2 to 3 injections, and they're looking at 1, 3, and 6 months post-injection. Some of the studies have a washout of PDE5 inhibitors. Some show that they allow them to use PDE5 inhibitors. Others tell them to stop prior to enrollment. So these are not standardized clinical trials, and it's hard to analyze the endpoints because of the trial design, and I'll speak more about that in a minute. Additionally, these are single-centered trials. The preparation of PRP, if it's activated, also not described. The endpoint for these trials is minimally clinically important difference in erectile function, and patients that are undergoing this treatment are either have mild to moderate. So you have to have a change in the IIEF's questionnaire of 2 points. I'll start with Tom Masterson's study that was published last year. These were patients with mild to moderate. They allowed them to take and continue PDE5 inhibitor therapy. And I think that that's a rational approach. I put this in here because this was the only paper that actually had a sample size calculation as to the minimally clinically important difference. They used an 80% power to detect a difference of 35%. I'm happy to talk more about this in questions, but in reality, for example, Irwin Goldstein's New England Journal of Medicine paper, sildenafil, had 532 patients trying to compare different degrees of mild, moderate, and severe erectile dysfunction, 532, to show similar changes here. So I would argue that sometimes when we're looking at these trials, we're not seeing potentially the appropriate power to detect a minimally clinically difference. This trial was negative, did not show an effect. The other two trials, which I pointed out, did show an improvement. They saw a change of 3 to 4 points for 1, 3, and 6 months, and they showed changes in Doppler. So at this point, all we can say is that it's safe. We appear to have patients with mild to moderate can have a change in IAF score, as well as MCID changes. The patient population is mild to moderate. These are patients that are responding to PDE5 inhibitors. These are patients that is not the goal of regenerative medicine. Remember, the goal of regenerative medicine is to take a patient with severe ED, replace organ function, and then allow them potentially to be PDE5 inhibitors. So I say, my point here is we have a lot more to go as it relates to regenerative medicine. What about low-intensity shockwave therapy? I'm not here to argue or to talk about the trials in detail. All I'm going to tell you is that it works in patients, once again, mild to moderate. There's a moderate improvement in IAF score and MCID. It is short-lived and it is not durable. There's no data to compare the different protocols and different generators. The best protocol, where to focus the ultrasound, has not been determined. And the EAU does recommend it for mild to moderate, weak level of evidence. However, our society and the AUA, the ISSM, ICSM, don't recommend it. However, my understanding is that there is a revisit of this to talk about potentially supporting it for patients with mild to moderate. And I think the data would say that it's safe, and at least in the 3 trials I presented, 2 of the 3 were positive. But I think we need to learn more about this, not 2 of the 3 that I presented, but in the majority. How do we improve efficacy? Well, combination therapy is clearly the best way to improve it. There is a trial that, the cocktail trial, which is looking at the combination of PRP with low-intensity shockwave therapy. Unfortunately, we don't have any data for this trial. It has been presented at a meeting last year, and it didn't appear, at least from the presentation that I saw, that there was much of an improvement, so I think we still have to wait. The problem is we still deal with the problem with power calculation in this trial as well. So the current obstacles that face regenerative medicine and ED are very challenging. The cost of therapy, ethical considerations, regulatory framework, the ability of our societies to support it, standard regimens, approved regimens, randomized controlled trials that are at multiple centers with an external review panel and company running it is what we need to be able to establish this. So my perspective is that there is evidence, I would say evidence in a disease state that we have a perfectly good treatment for, which is PDE5 inhibitors. And if we really want to take this into something that is going to impact our patients that need it the most, which is those with severe ED, then we need to do better, and the science has to catch up with clinical practice. Thank you.
Okay,